epidermis in the head is having columnar epithelium, very few sperms. As it advances, there are more sperms, then there is actually there is reducing the height of the epithelium. Eventually, in the cauda epididymis, you see that the sperm count is highest, but the epithelium is flattened, and there are in these different zones, you also see that there is an increase in myoid cells, eventually more in the cauda for helping in ejaculation. Here is a case of a completely depleted epididymal sperm lumen, and eventually because of impact on the spermatogenesis in the testis. Spermatoceles and sperm granulomas are common in epididymis than in the testis because of the the blood testis barrier. Although there is a blood epididymis barrier, but it is not as strong. If it is more than the 3 size of the tubule, then you call it as a spermatocele. When the immune system starts recognizing the sperms which are antigenically foreign, then the granulomas can also occur in the epididymis. Accessory sex glands, as I mentioned, all of them are present in the rodents. The prostate is dorsal, lateral, ventral and ampullary gland. Then you have the coagulation gland and the seminal vesicles. In the ampullary gland is where the secretion is the most eosinophilic, followed by the seminal vesicles. Like in any other organ, the degenerative, inflammatory, vascular and neoplastic changes can be seen in the accessory sex glands as well. Very important to note that these accessory sex glands are highly androgen dependent. The weight is more sensitive than the histology. Here is a case of an atrophy in prostate, seminal vesicle and coagulation gland. There are no secretions in any of these organs. A functional hypertrophy, when say for any reason increased hormones is seen, that these tubules are enlarged with flattened epithelium in all of these accessory sex glands. Preputial gland is also sensitive for hormonal variations. An atrophy can be seen if there is a reduced stimulus, and hypertrophy can be seen when there is a higher stimulus from the sex hormones. So, with that I move on to the female reproductive system. The female reproductive tract arises from the Mullerian duct. The female tract is formed by default. The ladies over here know it. By experience, the gents also know it. By default, they are correct. The male reproductive tract formation actually happens by infusion of the anti-Mullerian hormone and the testosterone during differentiation stages. The ovaries of most of the smaller laboratory animals are completely or partially enclosed within a bursa, whereas in humans it is freely hanging in the peritoneum. Ovary is a very complex one. It is involved in the production of fertile oocytes. It is involved in the production of steroid hormones and also synthesis of regulatory proteins. There are species differences. That is, in the mouse, ovary is more round in appearance, whereas the rat, lot of undulations are seen. Same is the case in dog, whereas in human, a clear medulla to the cortex differentiation is seen, where a lot of vascular and connective tissue is seen in the medulla. Estrus cycle in the rodents is of 4 to 5 days, and there are 4 stages: Proestrus, Estrus, Metestrus and Diestrus. The typical morphology is what you see. I will have pictures. I have pictures of this. Along with this, the examination of vaginal smears and vaginal histology is a common method to identify the stages in the rodent cycle and the evidence of cyclicity, which is can also be influenced by the toxicological effect of the compounds. Histological examination of the ovary, uterus, vagina should be conducted not only to determine the stage of the cycle, but also to assess the cyclicity and to identify and interpret the potential perturbations of the cycle. Evaluation of the mammary gland and the pituitary gland is also important when we want to characterize the impact on the estrous cycle. The female hormones are by the same mechanism, by the same methods like the RIA, ELISA and multiplex, you can actually evaluate these hormones, and again estrogen and its metabolites can be very sensitively evaluated using the LC-MS MS methodology. The hormonal variations are also different from species to species. A very good understanding of that is important while you want to incorporate hormone analysis into your study. The vaginal smear also, the cell types and the number both vary from the stage to stage. I will not go over this because I have a histological appearance that is more important for the toxicologist. So, in the Proestrus, I have a picture of ovary, uterus, vagina and the vaginal smear here for all of the stages. It is the late tertiary follicles that characterize in the ovary. That is the most easiest component that you can identify to state it as a Proestrus. In the uterus, the lumen is markedly dilated and it is filled with clear fluid by the end of this Proestrus phase. In the vagina, there are 3 distinct epithelial cells: the basal epithelium, the stratum granulosum and then the superficial mucoid layer. In the later stages, you also see the stratum corneum also appearing. In the vaginal smears associated with this, you see mostly the nucleated epithelial cells. They become progressively acidophilic, and some cornified epithelium cells are also seen here. In the estrus, it is the newly formed basophilic corpus luteum that is important to identify in the ovary, and in the uterus there is a lot of apoptotic cells. In the vagina, there is a lot of keratinized cells on the surface and in the lumen. And in the vaginal spheres, mostly that you see is the keratinized cells, but you also see few nucleated cells and other cells. In the Metestrus, it is the basophilic corpus luteum which is recognized, and but there are no healthy late stage follicles that you see here. The follicles of a different maturation is what you see, but not the tertiary follicles. In the uterus, it is the slit like appearance, apart from many other. I will not go into the details of each of these. In vagina, in the Metestrus, you see the complete dissociation of the stratum corneum, progressive loss of the stratum granulosum and the superficial layer of the basal epithelium as well. In the vaginal smear, you see leukocytes, cornified epitheliums as well, few of them, and the nucleated basophilic cells. In the diestrus, it is the corpus luteum that is formed from the current ovulation, which is lightly basic, which has reached the maximum size is the indication, and in the and then in the vaginal epithelium actually is the lowest thickness, and as far as the vaginal smear is concerned, you see a lot of mucus, the leukocytes, nucleated basophilic epithelial cells, and occasional the vacuolated cells as well. So, with this introduction on the estrus staging, the subgross anatomical changes is like there is a medulla and there is cortex. All the maturing follicles are seen towards the cortex and the corpus luteum. There are very few background changes that you see in the female rat compared to the male rat, very few. When it comes to the mechanism of toxicity, it is either direct toxicity or the indirect toxicity. Direct toxins are the ones which cause this without the hormonal mediation. Indirect could be because of the metabolites, the enzyme induction and hormonal imbalance. Eventually, several compounds can cause these changes. Eventually, you may see hormonal changes at the end. Follicle counting is not routinely done, but when you want to really see the impact on the ovarian toxicants, we do this, and that is by mostly by the proliferative cell nuclear antigen staining, and it will facilitate from primordial to the tertiary follicle evaluation. There is reduced variability and reduced time. Today, there are also use of artificial intelligence to count the follicles and report. Like in the seminiferous tubule staging, there is stage aware evaluation that we do here. So, what is done here is that the middle third of the ovary is cut into 5 sections 100 micron apart, and then you count the primordial follicles in all the 10 sections. The presence or absence of these growing follicles in the corpus luteum compared to the control is what used as a technology over here. So, with that introduction, I will move on to the pathological changes that are seen in the ovaries. Vacuolation can be seen in the theca cells, granulosa cells, interstitial cells, and in the corpus luteums as well. There is a normal vacuolation, but the change over that is what is recorded as a pathological change. Vacuolation can occur because the inhibition of the steroid synthesis leading to lipid accumulation within the cells, and other steroid producing cells such as the adrenal glands may also be affected. So, you should look at that. Corpus luteum, as the increased number of the vacuolated corpus luteum or vacuolation is observed in the corpus luteum of most recent vacuolation, and other than in the Proestrus is what we keep in mind. The foamy cytoplasmic vacuolation can be indicative of the phospholipidosis as well. Vacuolation may be, there is apparent enlargement of the luteal cells, and it is difficult to discern it from luteal hypertrophy in many instances. Here are the examples of the thecal cell vacuolation, the granular cell vacuolation, interstitial cell vacuolation, and the corporal lutea vacuolation. Atrophy, age-related atrophy is very common, and there was a very good question in the morning. It varies from tissue to tissue, in this case ovary. Cessation of the normal estrous cycle, age-related depletion of the primordial follicles, and changes in the endocrine responsiveness of the hypothalamic, pituitary and ovarian axis leads to this age-related atrophy. Atrophy also can be caused by the toxicant, by the reduction of the oocytes or the sex cord or the stromal cells. Alteration in the hypothalamic, pituitary, ovarian axis also leads to this. Corporal lutea atrophy is something that normally happens, and it may be also impacted by the chemicals, especially those which impact angiogenesis. I have a case of age-related atrophy over here. Neither the follicles or the corpus luteum is what you can appreciate here, and whereas in this case there is lack of corpus luteum, whereas the follicles are more. So, especially many drugs are known to cause such changes. I will touch upon in the next one. The corpus luteum can also increase in number. It can also decrease, as I mentioned. It can be completely absent. Here is a case of a degeneration of the corpus luteum. This can be impacted by the drugs as well. Here is a case of a kinase inhibitor in the corpus luteum, versus a degenerated with the immunization. In this case, this actually is caused by sunitinib, the anti-angiogenic compounds. Anti-cancer drugs have shown a lot of changes like this histologically. It's okay there because you're trying to treat a cancer even if there are reproductive toxicities observed. This picture is control versus the treated of a VEGF inhibitor given for 28 days, and you see marked reduction in the corpus lutea after treatment compared to the vehicle control. There can be complete absence or decreased number of follicles, and this again is is due to increased follicular atresia observed with many cytotoxic drugs. The sensitivity of the primordial, primary, secondary and tertiary follicles to this toxicity can vary according to the xenobiotic. The increased number of atretic follicles can also be seen. It is a physiological degenerative process through which many follicles are removed from the growing pool. It involves apoptosis of the follicular granulosa cells. The thickness of the granulosa layer is reduced as atresia progresses from early stage to the late stage. The oocytes can also undergo degeneration, and this as impacted by the radiation or the cytotoxic drug. The oocyte degeneration can be also observed in the absence of the granulosa cell changes. Atresia of the follicles begins with the degeneration of the oocyte and then accompanied by the granulosa cell degeneration. Here is the example of a decreased number absent follicles. In this it's shown mostly the medullary appearance and the corpus luteum that you see. Then increased follicles, increased number of atretic follicles that you see over here, higher magnification showing that the oocyte degeneration is probably the first one depending on the inciting cause that you see. The polyovular follicles can be seen. It is basically, it appears due to the failure of the normal mechanism of separating the oocytes during the formation of a primordial follicle in the neonatal rodent. The interstitial atrophy occurs as a physiological response to increases in the luteinizing hormone secretion or in response to a xenobiotic administration. The corpus luteal hypertrophy is also seen if there is an increased steroidogenesis or increased prolactin secretion, which will maintain this functional corpus luteum. These changes can be spontaneous or treatment related. It is an example of a polyovular follicle. If say compounds with the estrogenic activity, when they are administered to neonatal mice before day 5 of their birth, it can actually lead to increased number of polyovular follicles. The hypertrophy of the corpus luteum, it could be just one or two, and if not all of them that can be seen. It typically the corpus luteum, the most recent diestrus that are affected, not all of them can be affected, and the cells are enlarged and the weight of the ovary may be also impacted. In this case, there is also other reproductive organs that are also impacted, like the mammary gland, lobuloalveolar hyperplasia may be seen, and the lactogenic secretion can also be seen because of the increased prolactin in this case, and there can also be the emulsification of the vagina due to increased progesterone secretion in this case. Uterus, cervix and vagina. The uterus has a body and two elongated horns. The cranial portion is slit by the septum, whereas the caudal portion is a single chamber and then continues as cervix and vagina. The lining of the epithelium depends on where you are taking the histology. When it comes to the uterus, uterus is composed of loose connective tissue. On the outer, there are two layers of muscles, the longitudinal and the circular. In between, you have connective tissue and the vascular structures, and then the uterine glands and the lumen. The classical example of an atrophy is when you do ovarectomy, but several other compound related changes. When there is a reduction in estrogen and sometimes even progesterone, you will see atrophy. In this case, it is uniform. Every except the muscle, everything gets reduced in size, because these are hormone dependent organs. Epithelial hypertrophy in the uterus, here the lumen and also the glands can be tall columnar, and the cytoplasmic to nuclear ratio is increased. Since these cells contain a lighter basophilic cytoplasm, and these cells can contain lighter basophilic cytoplasm because of that increased energy demand there. Mitotic figures are often seen in these hypertrophic epithelium. The myometrial hypertrophy is also something that I've seen. It's more localized, enlarged and rigid, and the cytoplasmic volume of these smooth muscle cells within this myometrium is also increased. Here is the case of the epithelial hypertrophy. The nuclear to cytoplasmic ratio and the basophilia is the characteristic finding. Is the case of myometrial hypertrophy, a focal change. The size of these muscle fibers are increased. Some of the synthetic hormones have shown to induce this change, like the estradiol, benzoate. Many of them are used for anabolic steroids, like the nandrolone have shown this kind of a myometrial increased thickness. A focal decidualization, decidualization is has to be differentiated from a decidual reaction that happens when the ova is fertilized and get attached to the uterus. So the focal decidualization is more localized. You see a lot of nuclear and cellular pleomorphism and hypertrophy in one area. Especially the medical devices are the accidental antigenic response within the uterus can cause such a focal decidualization. Uterine cervix and vagina, vagina is a tubular structure. It is continued into the cervical canal and eventually into vulva. The outer layer has a loose connective tissue. There are two layers of muscle again here and an inner muscular layer. The muscle layers are arranged again like the inner one is the circular, the outer one is the longitudinal, and the epithelium is the squamous epithelium, which shows radical changes as I showed in the during the estrous cycle. An example of a vaginal epithelial hyperplasia here, almost all of the cells are hypoplastic here, and you may see invagination of the basal epithelium in this. In many places you may see cornified cells more attached to or inside the lumen as well. The keratinization increase in the vagina can it has to be differentiated. We have to actually compare it with the normal estrus, especially in if it's higher than what we normally see in the estrus stage. That's when we call it as hyperkeratinization. It is observed along with other changes in the reproductive tract in the female when the offsprings are exposed in utero to estrogenic compounds. So with this, I conclude and thank you for your kind attention after a very good heavy meal, and the session is open for, I think I have another 10 minutes, session is open for questions and answers if you have one.
So common changes happen, we see in the drug-induced toxicity and reproductive changes which can happen in the reproductive toxicity studies?
There are many, that like when it comes to the drug-induced changes, as all of the speakers are saying, it is either degenerative, inflammatory, vascular, proliferative. So this is where any change in any organ can be actually classified into these. When it comes to reproductive toxicity stages, it can go beyond this. There may not be any degenerative changes, there may not be any proliferative changes in the reproductive toxicity experiments. It's more to do with the hypothalamic, pituitary, ovarian axis, what kind of a changes that the compound impacts are and also the specific changes like damage to the oocytes directly, or the the maturation process, and so on so forth. I can tell that when you do a reproductive toxicity evaluations, you actually take a compound which is not toxic to the dam. It's a subtoxic in most instances. At that kind of a dose, is there a toxicity both by the direct or the indirect mechanism on the reproductive system is what is evaluated.
So, in case of 28-day and 90-day toxicity study, if we did not find any reproductive changes, so is it mandatory to do again a reproductive toxicity study, or we can stop?
It depends on the therapeutic indications for which you are developing the drug. If it is an anti-cancer drug, even if you see all of it, we record it and state it to the clinicians. I guess there are a few clinicians as well here that the compound can cause. But if it is for a non-life-threatening indication, obviously the requirements are much more and stringent as well when it comes to the pathological changes, when it comes to hormonal changes, when it comes to other changes like the sperm motility and impact of that on the fertility and so on and so forth. So it all depends on the context.